So, first thing I want to talk about this thing is, at least for me, it is a very theoretical subject because I have not diagnosed a case of carbon monoxide poisoning in the limited 1 to 2 years that I've worked in my ED. So, whatever I'm telling you is just theoretical knowledge that I've gained while reading one or two podcasts or basically Tintinelli and Rossets. And there is nothing much to discuss about it in so many details, just two or three salient clinical features. How do you diagnose it? How do you treat it? It is going to complete in around 20 to 30 minutes. So, but regardless, if you have any doubts as to regarding at whatever point my presentation is on, you can just put a message up in the group. And if I know the answer to it, I'll tell it. Else we have our seniors here who can help us. If not, I'll just go back, read it up, and by the next meeting, I'll tell it. So carbon monoxide poisoning. First thing I would like to say is this is a very important topic to be discussed in winter seasons because there is increased incidence of carbon monoxide poisoning, especially in the winter. So that is one thing that you should keep in mind. And it can present with a wide variety of symptoms. It can present with very mild headache to full-blown CNS manifestations. And to remember how carbon monoxide poisoning works, you should just remember one thing. I'll just talk about it in brief before moving through the slides. It is just that carbon monoxide poisoning, you should have a high suspicion when you are taking a patient out of a burning building. That is the one thing that I want to drive home. So basically, any fire victim, you should be having this suspicion that the patient might be poisoned with carbon monoxide. Also, you should have a high suspicion that this patient is poisoned with cyanide. So now itself, it should be very clear to you that carbon monoxide and cyanide goes hand in hand. And especially in a fire victim, when both of them combine, produces a synergistic effect to the body. And one of the mechanisms by which carbon monoxide and cyanide acts is by inhibiting your mitochondrial oxidative phosphorylation. So it brings a break to your aerobic metabolism. Thereby, lots of lactic acid is being generated in your body. So lactic acidosis, metabolic acidosis is a key finding that you can find in both carbon monoxide poisoning as well as cyanide poisoning. That's the first thing. And now that you understand this basic pathophysiology of both carbon monoxide and cyanide, the next thing that you have to understand is the rest of everything just follows on itself. Just give me 1 minute, I'll be back. Sorry for that. So the next thing is, now you understand that it breaks your aerobic metabolism. You do not have ATP generation, right? Which is like the most important thing. So whichever body part or organ needs oxygen the most, or the organs which consume oxygen the most are going to be affected first, and they are going to be affected the most as well. So naturally, the two organs that come to our mind is the heart and the brain. So in both carbon monoxide poisoning as well as cyanide poisoning, you are going to have cardiac manifestations, you are going to have CNS manifestations. So if you remember this much, the rest of the things is basically just theoretical part. And yeah, let's just go through the slides. So coming out to the slides, both Tintinelli and Rosen says that it is the most common cause of death in fire-related deaths. And it can be the most common cause of fatal poisoning worldwide. And it has a peak incidence in winter months. So that is the first thing that we already talked about. Second thing, it is basically can be generated from any sort of fires. And a special mention to methylene chloride, because methylene chloride produces some sort of a delayed poisoning in the patient. We will talk about methylene chloride if someone reminds me of it in the last. And coming to pathophysiology, our patients are naturally not going to be aware that they are going to be poisoned by a poisonous gas because basically it is an odorless gas, it is a colorless gas. And carbon monoxide is normally produced in the body as well as some part of hemolysis, and in also it can be raised in sepsis as well. So even in a normal healthy person, approximately 1% is like a normal value that you can find on your initial labs. So 1% is nothing to be worried about. Right. And the next thing that we have to talk about is the basic pathophysiology. We all know about this. We have been learning it right from our small classes, that the binding affinity of carbon monoxide is much more than that of oxygen. So it basically binds to hemoglobin, and it binds to hemoglobin more naturally in the deoxygenated form. So, and it almost has an affinity that is 200 times that for oxygen, and it has an even higher affinity for fetal hemoglobin, which makes the uh, kids in your, basically the fetus highly susceptible to carbon monoxide poisoning, which has an effect when we talk about later in the treatment. So basically, what you need to be giving is you need to be giving oxygen to the patient, and 100% FiO2 is the treatment, because it decreases the T half of your carboxy hemoglobin from 5 hours to 1 hour. And it can, even 80 minutes it's written, but it can be up to 60 minutes as well. And especially when you give high pressured oxygen, which is called as a hyperbaric oxygen, it can even reduce it to 1/10 of its original value. That is, from 5 hours, it can come down to 0.5 hours. So that is basically the first point that you have to talk about it. And this is a graph from Tintinelli showing that it can shift the oxygen dissociation curve to the left. And this is what we already talked about how carbon monoxide actually binds with the heme part, and it stops oxidative phosphorylation. It causes some amount of lactic acidosis. And it is more severe under hypoxic. That is, carbon monoxide interacts more with deoxyhemoglobin. And obviously, the compromise function is at the highest metabolic demand organs in the body. And one thing is, if carbon monoxide can bind to hemoglobin, it can naturally bind to myoglobin as well. So once it binds to myoglobin, the muscles function will not happen naturally. So it can lead to muscle breakdown. It can lead to some sort of rhabdomyolysis, usually not severe rhabdomyolysis, it's mild rhabdomyolysis. But this is an important cause where rhabdomyolysis is caused not due to trauma, but to some other reason. And secondary to this, the patient can develop some sort of myalgia as well. And where can we find the lesions? The lesions are most commonly found in the brain and the heart. So in the brain, predominantly what it affects is the basal ganglia region, especially in the globus pallidus region. There's a picture in Tintinelli which I forgot to attach. In the heart, it can produce your MI, your cardiomyopathy, myocardial fibrosis, long-term, and it can produce reactive oxygen species combining with nitric oxide and all. And there's always an increased risk of MI and stroke in the future. So all this is basic pathophysiology. One thing that you have to understand, again, just to summarize, is that carbon monoxide binds to your hemoglobin and oxygen cannot bind. First thing. Second thing is it inhibits your oxidative phosphorylation, just like cyanide poisoning does. So based on the first pathophysiology is where you're giving the person 100% FiO to your hyperbaric oxygen therapy, and it mostly affects your heart and your brain. And this thing we have already talked about. Patients can complain of myalgia secondary to its binding of myoglobin, and thereby your muscle does not function properly. It can lead to muscle breakdown, cause of heteromatic rhabdomyolysis. Now, how do you diagnose it? Really how to diagnose it, you need something which is called as a co-oximetry, something that at least we don't have in our ED to diagnose. One thing that you can find is your saturation probe that you have, it measures, it gives you a value 97, 98, and that is basically the oxygen concentration in the hemoglobins. That is what you're measuring. Thing is, even carbon monoxide also, carboxy hemoglobin also has the same thing. So it again will be read as an oxyhemoglobin, and it will give you the same value. So again, your patient might be dyspneic, but he is not going to be having a reduced saturation on your SpO2 probe. Whereas you run it by an arterial blood gas, there also you have an SpO2, right? That SpO2 is going to be less. So that is what we call as a pulse oximetry gap. So the pulse oximetry gap is basically the saturation probe that you have, which is also going to measure your carboxy hemoglobin. But the arterial blood gas that you take is actually going to measure your oxyhemoglobin. So there, the value will be less. So the difference, if there is a significant difference between both of them, you can call it as a pulse oximetry gap, and that is where you bring a supportive measure to the diagnosis that this patient could probably be having some sort of a carboxyhemoglobin positive. So that is the key point that you have to, that's the next key point that you have to understand here. And this is something that you shouldn't forget it, because this is the one of the kind of only diagnostic thing that can help you in diagnosing carboxyhemoglobin, carbon monoxide poisoning in these patients. And clinical features, different symptoms, right from headache to full onset coma. Second thing is your serious manifestations that can start right from chest pain, syncope, SOB, tachypnea. It can range up to your cardiac arrest. And the fifth point I've written myalgia. And in severe poisoning, you can find something like a retinal hemorrhage, or in patients who are having some prolonged immobilization. All the gases can get accumulated, and it can sort of result in something like a bullous skin lesions. So all this can happen, but let us just at the very basic area, let us just remember that it produces cardiac manifestations, it produces neurological manifestations. So a patient coming with headache. Now this is very important, because a patient coming with AMS, you are likely going to think of all these causes. But a patient who is having recurrent attacks of headache, especially in the winter months, you should have a strong suspicion. Now, diagnosing carbon monoxide is very difficult unless you have a high index of suspicion. And any patient with a recurrent headache, you must think of carbon monoxide poisoning, especially in the winter months. Now, some of the points that can help you to differentiate this carbon monoxide poisoning from others is very simple. Either the patient is getting the exposure at home, so he will tell you, or if you probe on the history, you will tell that, when I wake up, I have some sort of headache, but when I go to work, it is like kind of okay. But when I come back to home in the evening, again I have the headache. That is one history. Or if he's having an occupational exposure, he will tell that I'm having headache while doing work. So maybe you can localize the source to a particular point. The next thing is, whether you're at work, whether you're at home, wherever the exposure is, you are not the only person who is going to be exposed to it. There is going to be some people as well. So if the exposure is at home, what is going to happen is your family members are going to also complain more or less of these same symptoms. They are going to have some sort of headache and all. If it is an occupational exposure, your co-workers are going to have this headache. One important point that I found in the podcast is that even the pets can be susceptible. So any sick pets that you have at home recently can also help you augment this diagnosis. So that is a probing history that you have to ask with a strong clinical suspicion that can this be carbon monoxide poisoning. So that is just one point about headache that I want to drive home. These are some of the leading questions that you can ask to actually increase your suspicion that the patient might be having some sort of poison. And why we are stressing so much about we should identify this headache right from the point that it is a headache and not actually coming to an FND or a seizure is because chronic carbon monoxide poisoning can have delayed sequelae in the CNS symptom, in the CNS system. So you can have delayed neurological sequelae, and its incidence is quite high. It can rise up to 30% in some studies, as per Rossins, it has told that it can be as high as 30%. And the entire reason why hyperbaric oxygen is given to these patients is not for mortality benefits. It is actually to prevent the incidence of neurological sequelae. So that is one thing that is quite disturbing about carbon monoxide poisoning, that a patient who is having some mild headache might go on to develop some severe neurological impairment, and it is all because you couldn't diagnose the patient was actually having a poisoning in the first place. So that is something highlighting among the clinical features about headache. Two things that you have to remember here. One is that it is a neurological symptom. Second, that it is a cardiac symptom. Third thing, some points about headache and that it can have delayed neurological sequelae. And as I told you, headache when leaving home, similar complaints in families or pets. chronic poisoning is somewhat difficult to diagnose. Comatose patient pulled out of a fire scene is carbon monoxide poisoning until proven otherwise. You should always be suspecting cyanide poisoning in the patient as well. That is one thing. And what is it? AMS, high anion gap metabolic acidosis. Lactates, you should consider carbon monoxide poisoning. And it should also be suspected in a patient with cyanide poisoning. Both of them are going to be presenting with the same things. Basically, a patient is going to be in AMS, metabolic acidosis, and your raised lactates. So, and again, cyanide poisoning, is very quick. Carbon monoxide poisoning is also very quick. There is another toxicity. There is another particular overdose that can present in the same way. That is, the patient is going to be AMS with lactic acidosis and metabolic acidosis. Can anyone give a guess? Anyone who knows the answer? Or give a try? It is kind of an uncommon thing. Nehul sir will be covering it, maybe not today, if not today, in the next week. It is actually a massive paracetamol poisoning. So massive doses of paracetamol poisoning, which is defined as 1 tablet per kilogram, that is 500 milligram per kilogram of PCM toxicity, can make the patient symptomatic within hours, and the patient is going to be in front of you with AMS, raised lactate, and metabolic acidosis. So when you have a patient with AMS, raised lactates, and metabolic acidosis, your differential diagnosis should include carbon monoxide poisoning, should include cyanide poisoning, should also include something like a PCM overdose. And obviously, if the patient is in shock, he can have all this lactic acidosis. You have various other DDs as well. But from a toxicological point of view, this is something that you should always be thinking about. And so coming over here, and it says so in Rosen's that carbon monoxide poisoning should be suspected in every patient with persistent or recurrent headache, especially in the winter months. And the classical things that we learned about in our exams, the cherry red skin color, that is actually more typically found in postmortem, not much helpful for us in antemortem cases, and it is found in both cyanide and carbon monoxide poisoning. Again, showing how much of close relation cyanide and carbon monoxide poisoning is. And coming to clinical features, there is nothing much to talk about here. Patient is tachypneic, tachycardic, can be hypertensive or hypotensive, and the patient can have fever. All these features is also present in cyanide toxicity. And how do you interpret carboxy hemoglobin levels? First thing is, in smokers, it can anyway be raised. So the point is, a carboxy hemoglobin level cannot help you to diagnose, cannot help you to rule out. It is always a clinical diagnosis that you are making the patient, and you need a co-oximetry to actually tell you what it is. And even after that, a carbon monoxide hemoglobin per se is not going to tell you how sick the patient is. How sick the patient is ultimately, as always, at the end of everything, is your clinical gestalt. How the patient is improving your symptoms. So carboxy hemoglobin can be as high as 10% in active smokers. A 50% carboxy hemoglobin level is a marker of severe poison. That is something that we can tell. 50% definitely means severe poison. You need to do something for the patient. And again, the last point, rapid decrease in an elevated level is not an indicator of clinical improvement. So carboxy hemoglobin level is just an adjunct to your diagnosis. It does not rule in or rule out the diagnosis. And it can be raised in smokers. It is normally present in body as part of the basal metabolism, the hemolysis part of, right? And it shouldn't be used to guide treatment per se. Monitor the treatment. So that is what. A prolonged exposure to low levels can be fatal. Whereas a high carboxy hemoglobin levels with a brief exposure can have minimal symptoms. So it is not ultimately the carboxy hemoglobin levels that you're treating. Just like in septic shock, you're not treating the lactates, you're treating the patient. You look at the patient, you see how sick the patient is, and depending upon that, you treat the patient. And the other investigations include your blood gases. You will find metabolic acidosis, you will find lactates. ECG can have non-specific pattern. There is nothing much to say that this points towards carbon monoxide poisoning. Some amount of MI can happen to the patient, as we have already told. So troponins can help you. Imaging, as we told, bilateral symmetrical lesions in the basal ganglia, predominantly in the globus pallidus, is what you're going to see. Treatment, you need to reduce the half-life, which is the first mechanism. And for that, you need to put on your 100% FiO2. And till what point do you do it? Symptoms have resolved and your carboxyhemoglobin levels is less than 3%. So if it is again, your percentage is somewhere around 50% and the symptoms are not there, it doesn't mean that it shouldn't be done. Definitely, it should be continued till you find the normal carboxyhemoglobin level somewhere around less than 3. And once the patient is totally asymptomatic, fine, he can be observed for 6 hours and he can be safely discharged. When do you give hyperbaric oxygen therapy? There are again all of your cardiac things and all of your neuro things. Just write the most severe things and you'll get out of it. Any patient in coma, any patient with focal deficit, any patient throwing seizures, any patient with AMS, any LOC. And a patient having LOC is associated with delayed neurological sequelae as well. Older the patient is associated with delayed neurological sequelae. So any patient of LOC, it means that the patient can get sick, can have delayed complications even in the future. Right. So all those are your CNS manifestation. Basically, you write the extreme part of it. And even in cardiac thing, you just write the patient has a attack, has some arrhythmias, has some cardiovascular dysfunction and some hypertension. And naturally, coming out of the second mechanism, the patient is going to have severe metabolic acidosis. They have not defined a level, but I think you can keep it as 7.1 or whatever it is, depending upon the clinical status as well. And 50% is severe poisoning, 25% means that it is an indication for the patient to be started on hyperbaric oxygen. In pregnant, we told you that the fetus is more likely to get damaged, so you keep it at a lower levels. Right. And the important point is hyperbaric oxygen. I don't have a photo of it. It is basically you're kept in a chamber and there is pressurized 100% oxygen that you are getting in. You are trying to increase the pressure. You're somehow trying to make the hemoglobin to release all the carbon monoxide. So that is how it basically goes. And so that is it basically. So a very important point is patients can deteriorate inside the hyperbaric oxygen therapy. And once you're inside the chamber, if the patient becomes sick, there is absolutely nothing that you can do. So first of all, talking about this is itself theoretical because even we don't have hyperbaric oxygen therapy available. But let's just think about it in a scenario where we do have it. So what we are ideally supposed to do there is preemptively, if you are thinking that the patient is sick or borderline sick itself, intubate the patient, stabilize the patient as much as we can, and then shift the patient. Because if the patient gets sick inside the hyperbaric oxygen therapy, there is no coming back for the patient. Because it is very difficult for you to take it all out again do it. It's a labor intensive, it's a very costly procedure as well. So that is something that I have to stress here, that before putting the patient on hyperbaric oxygen, make sure you stabilize the patient as well. That includes airway protection as well. And again, the reason why you are doing it is a patient who is destined to die will die regardless of whether you give hyperbaric or not. But whether the patient is going to have a meaningful life or not is what is going to what you are going to achieve by giving the patient hyperbaric oxygen therapy. That is one thing that you have to be very clear. It does not have much mortality benefits. It has benefits in reducing the incidence of delayed neurological sequelae. Right. And you will have to start it as soon as possible because a delay of more than 6 hours is associated with lesser efficacy. And obviously, the disposition would include that the patient can develop delayed neurological sequelae. So you refer them for such evaluation on a 1-monthly exposure. And basically, that's it. And if the patient psychiatric consultation for all the other steps and all and all. And any prolonged exposure to the particular thing, any GCS less than 9 seizures, the patient will have to get admitted and all. We are not going to go too much into it. And this is the one thing that we talked about, delayed encephalopathy. Its incidence is almost as high as 40%. And once you develop it, there is nothing much you can do for the patient. Basically, you treat the patient symptomatically. Here also, you can try hyperbaric oxygen therapy. You can give some sort of antioxidants because basically it is some oxidative stress that is happening to the patient. You can give some sympatholytics. You can give some temperature control. Basically symptomatic treatment of the patient is what we do. And risk factors for development, as I told you, is higher the age of the patient and the patient has a history of LOC, more chances are that he's going to develop a delayed encephalopathy. And especially infants are more susceptible to this. Basically, the treatment is same, just that you have a lower cutoff for giving a hyperbaric oxygen therapy. And it is basically your fire victim. And in a fire victim is where you're supposed to be thinking of carbon monoxide as well as cyanide poisoning, and both of them has a synergistic effect, and both of them should be managed. A cocktail of treatment should be given to them. You should manage them for cyanide toxicity. You should manage them for carbon monoxide toxicity. Mehul sir, should I just take 10 more minutes and discuss about cyanide as well, or should we just break it further?
You can do that.
So that is how I think we should be learning as well, because carbon monoxide poisoning and cyanide poisoning should be learned hand in hand. Because you are going to get a patient, realistically, I think the most probable chance of us getting this patient is when a building collapses and a patient is, from a fire, and you're going to get the patient. So for all practical purposes, you are supposed to be thinking carbon monoxide poisoning as well as cyanide poisoning in the same patient. So you are managing the carbon monoxide poisoning for its part. How do you manage cyanide toxicity? So here, again, it is your oxidative phosphorylation that is going to get damaged. It is your organs with and tissues with high oxygen consumption that are the first and the most severely damaged. So what happens? Again, the same thing. Your heart and brain is going to be affected. Nothing new about that. And coming over to chronic exposure. Chronic exposure is again your your ataxic neuropathy that you find in a patient having cassava beans, because the cassava beans comes into you as sort of a delayed release of a cyanide, and the delayed release is going to slowly eat up your nerves, and it is going to produce your ataxic neuropathy. So that is just a side point that I wanted to talk. And one special thing is, this thing is metabolized in the liver by an enzyme rhodonase, and one of the treatments that we give targets this rhodonase enzyme so that a non-toxic component can be formed that can be excreted in the renal. We'll talk about that in the treatment part. Lethal dose for theoretical purposes depends upon duration, depends upon concentration. For 5 minutes, 700 parts per million can cause toxic dose. Whereas if it's 200, it has to be somewhere around 30 minutes exposure. And if you're ingesting it for some reason, as low as 50 milligrams, you can imagine a small diplo tablet, that can be fatal for you, as per some studies. But a typical dose would somewhere come around between 150 to 250. And manifestations are going to be same, except that it is going to more or less follow this order. The patient is going to be tachycardic hypertensive first, then the cardiovascular collapse ensues. The patient is going to have bradycardia hypertension, cardiovascular collapse, and not systole, it is asystole. I'm sorry for that. And CNS, headache, drowsiness, seizures, patient is going to have some pulmonary component because he is basically in some hypoxic kind of a state. So again, dyspnea, tachypnea, and apnea is going to be the pulmonary thing. And this pulmonary symptoms per se was not found in your carbon monoxide poisoning. Easily, I just kept in a different color. And the cherry red skin color, again, unreliable finding. And the classical smell that you find, the smell of bitter almonds. I don't know what is the smell of bitter almonds, but you can write smell of bitter almonds. And where do you get this poisoning from? Cosmetic nail remover. I think it's a nail polish remover that you're talking about. So that is one thing. The patient ingests that and you get cyanide poison. Second thing is the sodium nitroprusside that we use for treating hypertension. We don't have in our AD. But what is it? Spontaneous degradation into cyanide can take place, and it can be increased by using your sunlight and it's same with prolonged doses of infusion. So again, it is basically a repetition of carbon monoxide. Severe unexplained metabolic acidosis are consistent clinical features, and you can find very raised lactate levels. Carbon monoxide poisoning also, you are not going to find this much of raised lactates. Lactates of more than 10 actually correlates with your toxic cyanide levels. So this patient is going to be very sick very fast. You need to diagnose it very fast. And one ways by which you can correlate the amount of toxicity that the patient has is by looking at your lactate levels. And you don't need a cyanide level to diagnose toxicity. Similarly, you don't need a carboxyhemoglobin to diagnose. It just augments your diagnosis. And you do a whole blood cyanide level. a toxic dose is more than 0.5 mics, and your fatal dose is 2.5 mics per ml. So that is one thing. Treatment is again essentially the same. You are giving 100% FiO2. Hyperbaric oxygen per se, there are not much studies showing some benefits per se. So hyperbaric oxygen is something that is not routinely given in a cyanide poisoning because we have something else to give the patient. And you support the patient with IV fluids, vasopressors, and for the acidosis, you give the patient soda bicarbonate. And there are basically two types of treatment that you can give. One is your hydroxycobalamin kit. Second is your nitrite or thiosulfate kit. One thing that you have to remember is in a patient with carboxyhemoglobin levels, I mean, I'm coming back to carbon monoxide poisoning. You give the patient nitrite. Nitrite will react in the blood to form something called as methemoglobinemia. And methemoglobinemia is also going to contribute to this, which is going to increase your carbon monoxide toxicity. Because then even your carbon monoxide toxicity becomes more pronounced, especially when you have something that already your plenty of hemoglobin is damaged, you are adding nitrates, and the rest of the hemoglobin is going to get converted to methemoglobin, which is not going to help your patient. So, nitrate is something that you are going to avoid in your fire victim. You can give your hydroxycobalamin, you can give your thiosulfate, but you do not give your nitrate because nitrite can interact with your blood. It can form methemoglobin. It can worsen your clinical scenario if the patient has concomitant carbon monoxide poisoning. And for all practical purposes, unless the patient has a proper ingestion of cyanide toxicity, all of your patients are going to be fire victims. So fire victim patient coming to you with carbon monoxide and cyanide poisoning together, you are not going to be giving them your nitrate for the treatment. And this is just something about the mechanism as to how it does this. Basically, hydroxycobalamin contains cobalt. It is going to bind to your cyanide and it is going to get renally excreted. The dose is something over 5 gram over 15 minutes. You repeat the dose if the patient's condition worsens. And any blood samples that you have to be sending, you should be sending prior to the administration of hydroxycobalamin because basically it is a colored fluid that you are giving to the patient. It can result in laboratory errors. And nothing much bad as to giving, hydroxycobalamin to the patient. It can produce some transient hypertension, rarely anaphylaxis. A reddish discoloration of skin and mucous membranes is a non-adverse effects. So just the point is, a fire victim needs to be given hydroxycobalamin, and this is what you're going to be giving a patient. It is going to be 5 gram over 15 minutes, and the pediatric dose is going to be 70 milligram per kilogram. If the patient condition worsens, you can repeat a second dose. Nitrates, again, you're not going to be giving in a patient who is having concomitant carbon monoxide poisoning as well. It is going to produce your methemoglobinemia. And this, what happens is, we want the nitrates to form the methemoglobin because that methemoglobin is going to bind with the cyanide more. That is how it is going to be helpful in your cyanide poisoning as well. Whereas methemoglobinemia, you won't work in carbon monoxide poisoning for this particular reason. So what nitrates can you give? You can give your inhaled nitrates, you can give your IV nitrates. If an IV is available, you can give it directly IV. If you are finding it time to secure your IV, you can give inhaled IV. You can give your inhaled amyl nitrate. Right. So that is as simple as it is. And obviously, if your patient is very sick, is going to be in hypotension, but nitrate is the definitive management for managing the cyanide toxicity. So you are treating the underlying cause and you are not going to be worried about the hypertension because hypertension is going to be caused by a cyanide, which is going to be counteracted by giving nitrate to this patient. You manage the hypertension with your vasopressors and fluids, however you want. And thiosulfate. And now this is what is going to increase your rhodinase enzyme, which is going to produce the non-toxic thing and which is going to get renally excreted. And the important thing is thiosulfate has a synergistic action with nitrates, which is why it is combined with nitrates. It is given after nitrates. But again, if your patient is a fire victim, you do not have hydroxycobalamin, you can give thiosulfate, no issues. Just that you do not give nitrates in this patient. Okay. And for pregnancy issues, you can give the sodium thiosulfate. Sodium thiosulfate is preferred as a first line. That is one another theoretical point that one point that you can draw. Amyl nitrate, break it and you ask the patient to inhale over 30 seconds. Sodium nitrate, It comes in a vial. You can remember the dose later. Break a vial, give it over 5 minutes. Okay. You can repeat it if you want at half the dose. And the next thing is, for pediatric cases, please, there's a Tintinelli chart. Pediatric cases are always very difficult. You go on to Tintinelli, there's a chart. Based on that chart, you just give it. That is just one thing that I would like to tell you. So hydroxycobalamin, you can give it in all patients. Nitrates, you are avoiding it in your query carbon monoxide poison. And you can give your sodium thiosulfate. And when you're giving this particular treatment, it is told that if you're treating the acidosis soda bicarb, it enhances the treatment effect. That is isolated to using your nitrate and thiosulfate, and it is not per se seen when you use the hydroxycobalamin. Forget about it, even if you don't remember it, it is fine. Ultimately, you will have to treat the acidosis with your this thing. This is basically how you should be treating your pediatric cases. You can go back and refer to it. There are some other newly going drugs. You need to produce methemoglobinemia more faster. So instead of nitrates, you can give something like dimethylaminophenol. And instead of your hydroxycobalamin, there is something called as dicobalt and that also can be used. And as far as hyperbaric oxygen is concerned, again, not much evidence regarding the same, hence it is not used. So I would like to end my topic coming back to this one point, because at the end of the day, even if you do not know how to treat a case, it is fine. But we should know when we should be thinking about it. That is the important point of this. Diagnosing it is difficult. Once you diagnose it, treatment can be looked up into internally or outside. So you have your up to date, you can look up to it. This is the one thing that I want to drive home. The carbon monoxide and cyanide is going to inhibit your mitochondria, and it is going to produce lactic acidosis, basically switching over to anaerobic metabolism. More lactates are found in cyanide poisoning, and in carbon monoxide also you can find both. And a realistic scenario is your fire, where both of them are going to be coming together, and you're going to be excluding nitrates in your management of concomitant carbon monoxide and cyanide poisoning as well. So I hope I didn't go too fast, and this is as far as my theoretical knowledge goes. And please ask any doubts if you have. I am open to doubts, and that is it for me. For the
Okay,
a
Gautam,
quick
that
session.
was a very nice session. I'll just add a few points to add to the discussion. So you talked something about the saturation gap. We have a saturation gap with methemoglobinemia as well. So what is the difference between a saturation gap with the carbon monoxide and the saturation gap you see with methemoglobinemia?
I'm not sure, sir. I know the answer to that.
Yeah, somebody has answered it actually in the chat. Basically, what
The
happens in
saturation will be low. I mean, you are not going to get a raised. Your sp2 will remain low despite oxygen supplementation in a methemoglobinemia patient.
so basically saturation gap is basically a difference between your SpO2 and your the SaO2, the
Oh.
thing that you're seeing on the blood gas. So in methhemoglobin, what happens is that the SpO2 is low, but the SaO2 is actually going to be high, because most of the time you see this low SpO2 and start the patient on oxygen. So it will be more than 100, and whereas the SpO2 will be like 85 or something. So that is a pretty good sign that the patient is actually having methemoglobinemia. But what is happening in carbon monoxide?
Carbon monoxide saturation is again going to be high only, sir. Just that the patient is going to be more sicker because of the less oxygen availability. I'm not sure. Like, what is it that you specifically want to ask?
Yeah, well, it is going to be false. The SpO2 is going to be falsely elevated.
False elevated.
Yeah, so the problem with that is that clinically it's going to be very difficult to actually understand that you are actually seeing a gap, because if you're doing an ABG and
You
you
might
see that
mistake it that you are taking a femoral sample as well. If you are taking a femoral
you'll
sample,
think that the immediate reaction is that okay, I
I've
poked the
taken a
vein,
femoral sample.
I poked the vein inside of the artery. So
Uh,
detecting a saturation gap with carbon monoxide poisoning is a little bit
Yes, it is better. Okay.
more difficult, practically speaking. Another thing that I think wasn't discussed is a lot of these patients who are going to have carbon monoxide poisoning will have some degree of neurological dysfunction. They'll be altered a little bit.
Huh.
So, which patients would you put the patient on oxygen therapy, and which patient do you intubate? I don't think there's a hard and fast rule or anything. Just
Again, I'm not sure as to the answer. So clinically, you might see the patient and you might decide this patient might benefit from an airway protection more than anything else is what I would say, rather than going at the how hypoxic the patient is. Because ultimately the patient needs 100% FiO2, which you can provide either ways. That is how I would manage. I would just look at the patient, whether the airway is threatened as well. If I feel that the airway per se is threatened, then maybe I would go in for an intubation and not just because the patient is hypoxic.
yeah, that's true. And probably if the patient is throwing seizure, then probably that's a good time to actually rather than just putting the patient on oxygen and seeing. Another thing that I feel that I manage is I think one or two cases of carbon monoxide in residency, and after going back and reading, I think the mistake that we probably made is that we did what you wrote and we put the patient on NRBM, 50 liters per minute, which may not have been optimal. It might have been more optimal to actually start the patient on HFNC because this patient might be benefiting more from a higher flow rate,
I
like with
understand.
40
Some
liters.
amount of pressures.
Yeah, so you can put the patient on HFNC, or if the patient is conscious enough to tolerate, maybe we put the patient on NIB. That might be a better option than just putting the patient on NRBM and waiting. So that is one thing. And another, some practical experiences. So these patients can be very tricky because they'll be coming with all these kind of vague symptoms, and especially if they are young, and especially if they are female patients, you will tend to label them as hysteria. So that is a grave mistake that we are prone to making, and that is why things like functional disorders, they are always a diagnosis of exclusion. So one time there was one of my seniors actually almost fell into this trap until he looked at the blood gas and found that the carbon monoxide level was very elevated. So that is something that you should keep in mind. Um, I don't have anything else to add. I think if anybody else has anything, we they can speak now if any doubts or anything.